Hello everyone, I hope you're all well. This is Carl Monaghan from the Pelvic Pain Clinic in London. This is the second presentation looking at the BioPsychoSocial Approach to treating chronic pelvic pain syndrome and chronic non-bacterial prostatitis. If you haven't seen the first one, it's not a problem. It's not essential for viewing, but it might help in terms of understanding some of the key concepts we're going to be covering today. So what can we expect from today's presentation? Well, we're going to look a little bit of research. We're going to look into current barriers to treatment from a traditional viewpoint, more the kind of the GP, the urologist side of things. We're going to have a look at patient alliance and our responsibility as therapists to our patients. And we're going to see what we can do as therapists to get better outcomes for our patients as well. There'll be a number of resources for patients to gain a deeper understanding into their own pelvic pain. We're going to tie it all together. I'm going to give some final thoughts. And then I am back here next Thursday, that's the 21st of December at 11 o'clock again, where I will be covering hard flaccid. A relatively new presentation, and certainly one that's very, very poorly understood and very poorly commented on at the moment. Here I am. I just thought I'd say hello. I will be appearing at the top corner of your screen, so I will be in the background of all the slides. If you like what you see, please comment. If you feel anyone else might enjoy the presentation, the information involved, then again, please do tag them as well. On my Pelvic Pain Clinic website, I will be posting up all the references and resources from today as well, so please feel free to go through to there. I will then post the blog post back onto the Facebook page as well, so all of that information will be there. Okay, so let's crack on, and we're going to start to look at what I call some of the barriers to treatment. Now, this is a fantastic research paper by Dr. John Rees et al. There were some really interesting specialists involved in this particular research paper that came out 3 years ago now, as you can see. Now, this was supposed to be reviewed in September of this year. Now, I don't know if it has. I certainly haven't heard anything. It may well be in the process at the moment. Generally, if these things are to be reviewed, it can take a little bit of time. So, why is this paper really, really important? Well, for me, the Prostatitis Expert Reference Group, which was set up in 2014, the PERG reference group, was set up in association with Prostate Cancer UK. And this was to develop a consensus of guidelines to improve the diagnosis and management of men with chronic bacterial prostatitis, and more importantly, and for my area of interest, chronic pelvic pain syndrome and chronic prostatitis. Now, the aims and objectives of this particular paper were to provide guidance to healthcare professionals treating patients with chronic bacterial prostatitis, as I've already said, and the non-bacterial side of things, both in primary, doctors, GPs, and secondary care, urologists. And it was to facilitate the improvements of patient awareness and recognition of these particular set of symptoms, because it's so poorly understood. And up until this point, the Prostatitis Expert Reference Group agreed that actually it's been really, really poorly managed, really poorly treated as well. So I'm going to run through some of the comments and some of the key aspects, in my opinion, from the paper. We're going to look at an algorithm in a second that they put together to help therapists be able to treat patients more effectively. So the bit we're going to focus on is chronic pelvic pain syndrome and chronic non-bacterial prostatitis. So, according to Dr. John Rees and co., patients with CPPS and chronic prostatitis should be managed according to their individual symptom pattern. No single management pathway is suitable for all patients with these conditions. That's really key. An individualised management protocol based on the individual. Like, that's an awful lot. Most patients with chronic pelvic pain syndrome, chronic prostatitis, do not have an infection, and repeated use of antibiotics such as quinolones, this is your Cipro, your levofloxacin, your ofloxacin, should be avoided where no obvious benefit from infection control is evident or cultures do not support an effective etiology. So where there's no infection found or there's no response to antibiotics, treatment using antibiotics should stop. Really important. Early referral to specialist services should be considered when patients fail to respond to initial measures. And referral should ideally be to a clinician with an interest in the management of these conditions and or CPPS, but not necessarily a urologist. So I think the paper written by a urologist, Dr. John Rees, is a urologist, Dr. Andrew Doble, also a urologist, contributing partners as part of the expert reference group, realised that actually maybe urology isn't the answer in treating chronic pelvic pain syndrome. A multidisciplinary approach should be implemented and made available to all patients suffering with this particular condition. And patients should be fully informed about the possible underlying causes and treatment options. The multidisciplinary team responsible for the management of these patients should be able to explain the chronic pain cycle and other relevant information to improve patient understanding of the conditions. I haven't come across one single patient who has been to a urologist and been explained the chronic pain cycle. For me, pain neuroscience education is a huge part of our responsibility and our role as therapists. And if we're not informing our patients as to what the chronic pain cycle is, and guess what? I'm going to be doing a Facebook Live presentation on this in the new year. So I'm going to give you that understanding as well. That if patients aren't being given the understanding as to what this chronic pain cycle is, how are they supposed to understand what they're going through? How are they supposed to understand what pain actually is and what it isn't? So these are key recommendations that were put into this paper back in 2014, and the idea here was that they were to support and offer a consensus of guidelines to people like NICE. Now this is here in the UK, so other countries across the world, they may have their own consensus guidelines, they may have come up with their own expert reference group. In Europe, the European Association of Urology release papers roughly every 4 years on the management of chronic pelvic pain syndrome and chronic prostatitis. It's a great paper, it's a massive paper, but if you're interested as a therapist or patient, that's a good reference. I will put that also in the blog post for you as well. So, according to PERG, according to this research paper, in patients whose symptoms persist, despite no identified bacterial cause and no response to antibiotics, the management should be guided by the symptoms present, by the individual again, not just, right, we're going to use the same protocol for every single patient that comes through. And how rewarding is that for the individual, the patient? How empowering is that should be for the patient as well, to know that they're not just going to get an off-the-shelf cookie-cutter approach that the previous patient and the next patient's going to get as well. If a bacterial cause is excluded, and this is where there's a bit of a grey area. Now remember, these are guidelines. This is what they'd like to see in practice. So if a bacterial cause is excluded via a urine dipstick test, there are better tests out there, or a urine culture analysis like the STAMI test. And what was really noticeable from this paper is they encouraged and they pushed and they wanted these kind of tests to happen so as that they could rule out bacterial infection. So if a bacterial cause is excluded and no patient symptom improvement is observed after antibiotic therapy, a different treatment modality or referral to a specialist must be considered. So antibiotics aren't working, let's try something different. That's revolutionary. Patients who don't respond to treatment should be asked if they have a history of trauma, including physical, emotional or sexual abuse in the past. And this includes during childhood. I'm going to comment on this on my next slide. So there was a suggestion that chronic pelvic pain syndrome, chronic prostatitis might be as a result of some form of physical, emotional or sexual abuse in the past. Let me come back to that on the next slide. And the guidelines from PERG were that the treatment of chronic pelvic pain syndrome patients requires input from a multidisciplinary team. So not one specialist should be used across the board. That actually having other people involved in this is really, really important. And this includes pharmaceuticals, physical therapy, and psychosocial approaches that are integrated into a holistic treatment program individualized for the patient. How wonderful is that? How nice is that to hear as a patient? Let me repeat that. So a multidisciplinary team where we get intervention from using pharmaceuticals, that's medication, physical therapy and psychosocial approaches are integrated into a holistic treatment program. Biological, psychological, sociological approach. Individualised to the patient. Awesome. We like that an awful lot. That's the reason why I'm doing this presentation. Okay, let me show you the PERG algorithm. So an algorithm is recommendations and suggestions for how treatment should progress. It would be worthwhile if you have the ability to see this on a bigger screen to get some of the details that are in here. So, what are we looking at here? Well, in the top 4 boxes across the top of the screen, it's what traditional medication is used. Alpha blockers, antibiotics, NSAIDs, the AAA approach. And then there should be a follow-up at 4 to 6 weeks. Most patients I've seen have had follow-ups anywhere between 6 months, sometimes 12 months. And then if the patient comes back and they're still getting their symptoms and there's no bacterial cause identified, then there should be a consideration for sexual abuse. Again, I'm going to comment on this very shortly. If there is a bacterial cause confirmed by doing something like a urine dip test or the STAMI test, again, they're really encouraging the chance for patients and for therapists to rule in or rule out bacterial infection. Why this isn't being done, I have no idea. Very frustrating. That if there's a partial response, maybe another course of antibiotics should be considered, possibly. But that there should be a consideration again of sexual abuse and or trauma and psychosocial factors and or yellow flags. So let's go back a little bit. Let's talk about this, the abuse side of things here as well. I've been treating male pelvic pain for 9 years. I've come across 2 cases in my time of sexual abuse where the patient feels it's relevant to their particular case. Now that doesn't mean that there aren't more cases of sexual abuse in and around chronic pelvic pain syndrome. I think this is highly evaluated, highly underrepresented. I don't know what the true effects are. I'm going to give you an example of 2 papers very shortly that are very contradictory of each other, but well worth referencing or looking up if you're interested in this. So because I've only had 2 patients that have been open with me, excuse me, it doesn't mean there were more patients who had sexual abuse or trauma. What I would say is that I like the word trauma because trauma is a little bit more, and not sexual trauma. Trauma can suggest a whole variety of different things, and I think is more, in my opinion, closer to the reasons why people end up in chronic pelvic pain syndrome. Whether it be life trauma, a bit of physical trauma to the area, sometimes even the trauma of actually having been to see urologist after urologist, gum clinic after gum clinic, GP after GP, being told some of the things they're told. And again, we're going to explore some of the language that can be used and some of the barriers as to why patients end up in the vicious cycle they end up in. So, sexual abuse and trauma. There are 2 papers, they're on the blog post, and the first one from 2007, I'm not aware of any other papers documenting sexual abuse here, so if there are, please forgive me, there might be some more out there. The first one from 2007 took a sample of about 5,500 men from the Boston area, aged between 30 and 79. They ran a series of questionnaires, etc., and they found that actually there was a relatively high rate of abuse in child and adulthood in those patients presenting with chronic pelvic pain syndrome. A year later, a much smaller group of 180 men, both with and without pelvic pain, were assessed and were asked to complete a number of questionnaires, and actually the number of those patients presenting with chronic pelvic pain syndrome, chronic prostatitis, who had a history, reported history, of sexual or physical abuse was actually relatively low. So I think it needs more exploration. Some patients might be happy to talk about it. For some, it may be too traumatic to bring up. So it's a consideration, a psychological, biological and sociological consideration when treating our patients. What are yellow flags? I hear you say. So a yellow flag is something that involves, so we have red flags, and red flags in therapy are generally considered to be potentially life-threatening, something that needs direct or very clear attention. They are medical conditions that need serious treatment. Yellow flags, however, on the other hand, are more to do with the psychosocial factors of the individual. And they might consider things like disability or work loss, and if they're to be detected. So if when a urologist is having a chat with a patient around their particular condition and they're presenting symptoms, and they feel that there are some psychological, maybe some sociological issues that are coming up, then that's a yellow flag. And if there's a yellow flag being identified, then that patient is supposed to be referred onto, and you can see here further down in the boxes about halfway down the algorithm that say pain, psychosocial symptoms, urinary symptoms and sexual symptoms. Under psychosocial symptoms, if the assessment suggests there are psychosocial issues, then that patient should be considered to be referred to specialist care to get the necessary support. Again, that sounds great. That sounds really important. We're looking at the individual. We're looking at ways in which we can treat the individual on an individual basis. And there's no point spending time identifying these yellow flags if they're not going to be followed up either. In the box under the psychosocial symptoms, it's indicated that PERG recommend that something like a GAD-7 or a patient health questionnaire 9, the shorter version, is used. So GAD-7 is a general anxiety disorder, and there's a series of questions. Again, these are going to be on my blog later on, and I'll talk about them very shortly. What tends to happen to most patients is they get trapped between the two black boxes. Symptoms persist and symptoms persist, and they end up in a tumble cycle between the two of them. Back to urologist, back to GP, back to gum clinic, given some medication, symptoms change a little bit, nothing really happens, follow up, and they end up in that vicious cycle. That for me is not productive, and it means they're not progressing any further with their treatments, and that's very frustrating for the individual. So why is this actually happening? Why are these things not progressing in terms of current medical care, so urology, GP, gum clinic, etc.? And I would argue that a lot of it is down to the way that it's being run at the moment. And there are a few key issues here. I don't think we can blame individual urologists. I think that's completely unfair. I think it's a product of the situation that involves chronic pelvic pain syndrome. It's a poorly understood, poorly referenced, poorly researched. And at the moment, to spend time with individual patients at a urology or GP level, it just isn't practical. The amount of time that patients are given in the medical world is such a short space, it doesn't allow to explore these other possible contributing factors. So actually there's a very small window of opportunity, time window of opportunity to discuss these before the patient's given some medication and often told to come back in a period of time. 3 months, 6 months, 12 months, whatever that might be. And we can look at the training as being a bit of an issue here as well, that conditions like prostate cancer, like benign swelling of the prostate, BPH, like urinary incontinence, like sexual dysfunction, are generally treated on an individually, as in each of those conditions individually, pretty well. But with chronic pelvic pain syndrome, chronic prostatitis, there's no money in what's happening. There's no funding, there's no research, that is not being underpinned. So actually to build up a protocol, to build up a greater understanding, this is why PERG are so important in all this, because they're helping to support nice guidelines. They're making recommendations and suggestions as to what could be done for this patient cohort, this patient group. And most of the psychosexual nurses that I've worked at that patients could be referred onto, they don't particularly have a great track record in dealing with, I'm speaking generically here, there are some great psychosexual nurses out there who do a wonderful job, but on the whole, that it's not very well treated, and like I said, individually. So erectile dysfunction, maybe issues with the bladder, those things are treated pretty well on an individual basis, but you chuck them all together, pain, you chuck urinary symptoms, you chuck a whole host of these symptoms together, and it becomes quite hard to treat from a psychosexual point of view at the moment, in terms of training at the moment. And if we look at personalised programs, well, this is, again, a hard thing to come up with because it takes time, because it takes commitment. And we shouldn't use an off-the-shelf approach for every single person because it's not personalised. We know that PERG are recommending and suggesting that, so we do use personalised programs. And, when we compare women's health specialist service to men's health specialist services, well, we know that there are women's health specialist services within the NHS, but men's health specialist services don't really exist. Most men with these particular set of symptoms end up having to go to women's health practitioners. And that's great, but it places a great deal of stress on those female practitioners. Some of them may not be comfortable seeing men. So again, the patient ends up being kind of pushed from pillar to post. And although PERG have put this set of guidelines together to advise people like the NHS and NICE guidelines are in place to offer the most cost-effective and time-effective treatment for patients. And under NICE guidelines at the moment, you can find this on the NICE guidelines website, they advise that a patient who's suffering from these symptoms from CPPS, non-bacterial prostatitis, should be referred to a specialist, but there's no guidelines as to who that specialist should be. And I think that's a real shame. And in the long run, I'd actually argue that although it should be, NICE guidelines should be in place to be cost effective and time effective, I'm not sure that the individual patient actually the treatment ends up being cost and time effective because it takes such a long time to go through that. So you can see the kind of conundrum that we're in and why this research paper was so, in my mind, important in moving things further forward. And I hope there's a new set of guidelines that comes out. I hope that there's more information on this for NICE, for NHS, and for treating patients moving further forward. All right, let's move on. I'm going to show you a slide now that's been floating around for 20 years. It's a bit text heavy. There's a few slides today that are a bit text heavy. I do apologise about that. But I think it's really important to give you as much information as I can around this. So this is actually a slide that PERG use at their meetings to do with prostate cancer. When they do, when PERG make presentations for Prostate Cancer UK or under the Prostate Cancer UK banner, they always show this slide. And what I find interesting is that it's almost 20 years old now. But the message is still really key. So you can read this, but most urologists freely acknowledge that they would be happy to never see a patient with prostatitis in their office again. Some simply refuse to treat patients. Many ignore the real issue, dispensing their antibiotic of the month. Now, I don't think they're antibiotics of the month at the moment. Remember, like I said, this is 20 years old. However, fluoroquinolines, including ciprofloxacin, levofloxacin and ofloxacin, are generally considered to be the better type of antibiotic in the treatment of prostatitis because it's able to penetrate deeper within the prostatic tissue. And many urologists hope that that if they ignore their patients, then they will not return. This approach has resulted in frustration and even anger on the part of the patients as they shop around for a compassionate urologist or suffer without help from the established medical community. I don't think much has changed, sadly. This is the reality of what's going on. So how do we move through this? How do we change? And what is our message as healthcare professionals, whether we are no matter what level we're treating patients on, what is our message? So this next paper is from, it's actually from a lower back pain paper, but I'd still argue that the message is really relevant and could be considered generally across many health approaches. Again, it's quite text heavy, so I do apologise. And so healthcare professionals have the strongest influence upon their patients' attitudes and belief, over and above the internet and family and friends. And clinicians influence their patients for many, many years, and they influence the beliefs of their patients for many, many years. And this could result in increased vigilance, worry, guilt, frustration, and protection strategies that often fail the patient. However, on the flip side, if we spend a bit of time, if we explain what's going on, if we give patients the care and the attention and an individualised approach, we can actually provide reassurance. We can increase confidence with the individual and advise positively around key outcomes and key approaches to improve movement and activity in patients. You can probably now see why it's relevant to lower back pain. But I love that message. I think that's really, really key. And I think we should all be a little bit more considerate of the language and terminology that we use with our patients. That includes me as well. Second message, again, another research paper. And if you do have time to read this, it is well worth taking the time, patients or therapists alike. What we need to consider that is whenever we give a treatment to any individual patient, it's not done so in a vacuum, but in a complex set of psychological states that vary from patient to patient, from situation to situation, and from treatment to treatment. So the patient you see at the first treatment is going to be different to the patient you see at the second treatment. They're the same person, you get that though, but they're going to have other things, other baggage that they're going to carry with them. And this paper was particularly key because it investigated the complex psychological factors like placebo and the effects of doctor-patient relationship by using physiological and neuroscientific approach. And one of the key messages was that curing the disease is not sufficient enough, that we must care for the patient, and that should be of paramount importance. That there is a mind-body interaction, and that the patient's mind, cognitions, emotions, everything plays a really central part in recovery. And the role of the doctor and the healthcare professional and the patient, that particular relationship is vitally important. And what happens during these interactions is vitally important as well. And I haven't put this paper on there, but I just want to give you an extract from, again, a very long study by Resnick back in 2003, but actually the information was very, very relevant. And it examined 12 therapists who are either classified as expert or average based on the outcomes of their patients. So they asked the patients what they felt these specialists were, expert or average. And what the findings were that expert therapists were not distinguished by years of experience. Instead, expert therapists had a patient-centered approach to care, characterised by collaborative clinical reasoning and promotion of patient empowerment. Now, what we must consider is that there is a patient that we're treating, that there is someone on the end of the Skype consultation, at the other side of the consultation desk, wherever that may be, at the other end of the telephone, that is receiving this information, and that we have a responsibility to be able to deliver that in a key and appropriate fashion. Sorry, I'm just mindful that the stream seems to be a little bit dropping in and dropping out at the moment. I will continue. All right, so let's look at some issues around treatment and why, what we can do for our patients in order to improve the outcomes, in order to improve our relationship with them as well, and things that we could consider ourselves to do better or to do more of. Now, a therapeutic alliance is really key, and that's a description of the interaction between the therapist and their patients. And by establishing a therapeutic alliance, therapists can seek to provide patient-centered care in which this therapist is seen as a facilitator, and and in order for the patient to achieve their goals, rather than an authority figure. So rather than someone that the patient has to rely on heavily for recovery, this is more about guiding the patient to their best outcome. And this is accomplished by encouraging the patient to become more active in their treatment, to engage them in collaborative, active approach to recovery, by establishing a strong therapeutic alliance and encouraging patient participation in all aspects of their recovery, the biological, the psychological and the sociological. Now, this isn't anything brand new. This has been around for over a century now. Freud, back in 1912, was the first one to really kind of look at therapeutic alliance. In the mid-50s, Rogers highlighted the relationship between empathy as a core characteristic in terms of therapeutic alliance and patient compliance as well. And more recently, it's been conceptualized that both empathy and rapport have really key and relevant factors in terms of the therapeutic bond. We need to have a patient focus in our approach as well. And instead of indicating there are thousands of cases like the one that you're presenting me with, of the person who's in front of me at the moment, we should never consider the individual. We should consider the individual who's in front of us, who's receiving the treatment, and we should always consider the individual. That by telling the patient in front of us, this is a quick fix. We've seen thousands and thousands of cases like yourself. This won't be a problem. This will be easy. Follow our protocol, and you'll have no issues in terms of your recovery. I think that's the wrong message to give. I think it is a false statement. And we need to be open and honest with our patients as well. They must be placed at the centre of their recovery and their treatment. Now, that sounds like a very simple, straightforward thing to say, but many times that's not the case. We can deliver the same message to our patients. We can have key curriculum messages. We can have key concepts that we want to pass on to our patients, but they must be delivered in a way that's suitable for that individual patient, in language and terminology, in an approach that that resonates with the individual. So, for example, a range of my patients, am I going to deliver the same message to my neuroscientist patient as I would to the London cab driver? Am I going to give the same data and stats that I would to the urologist patient I'm seeing as I would to my politics student? What about international patients? What about in terms of presenting information that they can understand and they can assimilate to? That is vitally important, that language can be a barrier, that having the right message and the right language and terminology is essential. What about my retired footballer? How can I deliver the same message time and time again without making it individual to the patient and expect the patient to understand what I'm talking about, but also to get the right results that I'm looking to achieve and that they're looking to achieve? And listening. Again, really, really sure that this doesn't need much introduction, but I do, however, see this as a central point in terms of forming a good patient alliance. And there's an awful lot of research out there at the moment that does suggest that we, as therapists, quite often don't hear or listen to our patients probably as much as we should do. And Bill Taylor, one of my teachers, someone I hold in the highest of esteem, was teaching in Israel last week, and he reiterated that we must listen to our patients and then listen to them again. And we understand how key it is to listen, but sometimes you don't allow that to happen. Patients often with these set of symptoms need to talk. They need to express what's going on for them because they don't have anyone to talk to. They don't have anyone to be able to offload onto. It can be a very lonely and isolatory condition to deal with. All right. So they're fairly straightforward things, but what about how do we put this into practice and why should we be doing this? And again, I'm going to underpin this with research. I'm going to go back to a paper that I explored in the first presentation. And it's a paper I enjoy an awful lot. It's a paper I love reading. I think it's very, very key for the message that we should be giving to an awful lot of our patients as well. And this is the psychological factors, social aspects and psychiatric comorbidities associated with CPPS and chronic prostatitis. I'm going to pull out, again, some key points from it. Some of these are similar to the ones I pulled out last week. Some of them are slightly different. We're then going to look at ways in which we can address some of these in the clinical setting and how we can gain a deeper understanding into some of these key messages here. So in this systematic analysis, and a systematic analysis is where someone else does my work for me. They read through all the research. They assess and check and put it into a nice research paper that I can read and then read back to you as well. So some of the key aspects from this particular research paper: a quarter of patients reported feeling helpless or hopeless. Remember, I'm reading these out to you now because what we're going to do over the next few slides after this is give you ways in as therapists to try and open up conversation with patients around some of these key things. And for patients to be aware that there are routes into having a greater understanding into the reason why you're getting your symptoms at the moment. So patients, you can also fill out these forms. Therapists, I would encourage you to consider using these or something similar in your practice. I'm not the oracle. I don't know all the answers. I would never claim to know the answers. I think that's a falsehood. But and the way I run my practice, and I'm going to give you a little insight into it in a bit, is not the way that as therapists you should necessarily run your practice. It has to be down to you and what you feel is right for you. Let's go back to the paper. So a quarter of all patients reported feeling helpless or hopeless. Pain catastrophization predicted pain intensity. Half of these patients believe that stress increased pain. And the more stress patients perceive during the first 6 months after their initial visit to their healthcare provider, the more pain or disability was reported at 12 months after the initial visit. This is really interesting. Poor partner support led to greater feelings of pain and disability, and there was an association between severe pain and low satisfaction with relationships. There was also an association between depression and sexual function, and this led to increased pain catastrophization. There was a correlation between depression and chronic pelvic pain syndrome, chronic prostatitis, and symptom severity. There was also psychological aspects, so pain catastrophization, stress and personality changes, and social aspects, and this is particularly relationships, whether they are on a romantic notion, whether it's at work, whether it's with friends, or in a physical or sporting or hobby type situation. And spousal support and social interaction played an important role in the feeling of disability. So these are some key points from this research paper. And now I'm going to cover some ways that we can actually gain insight to our patients, ways that patients can look at their own presenting case. They can fill out some of these forms and actually then take a look at maybe some of the contributing factors they hadn't considered beforehand, or maybe had but weren't too sure how to work through. Now again, the way I run my practice, it's a private practice, so I'm able to spend a lot of time with my patients. On original inquiry, I send out my intake forms, and the intake forms you can see on this page here are the majority of the forms I send out. I do have a general pelvic pain questionnaire that I send out, including other lifestyle factors, so diet, nutrition, medication, previous surgeries, previous injuries, etc. as well. Once those forms are completed and sent back to me, I arrange an initial Skype or telephone consultation, which lasts about half an hour. And during this Skype or telephone consultation, I go through the forms, pull out key bits, and we discuss them. And we come up with a bit of a plan. And sometimes I refer my patients on to other specialists at this point. I'm not the oracle. I don't know all the answers. I'd never claim to know all the answers. And sometimes, using a multidisciplinary approach, getting other people involved in this is really, really key. And I do use a number of therapists that have a CBT, so cognitive behavioural therapy, or NLP, a neuro-linguistic programming approach, because I feel that I don't have the tools, I don't have the ability to be able to deal with some of those other aspects, and patients do need additional support. So, I am just going to take you through some of these forms and just outline why I feel they're really important and should be considered. There are other forms out there. And I think if you're a therapist, it's important you explore ones that resonate with you and give you the information that you need for your practice. So the NIH-CPS, that's the National Institute of Health Chronic Prostatitis Score Index. There should be an I on the end of that, I do apologise. And this is something the National Institute of Health have put together. It's very symptom-based, and it looks at pain, quality of life, urinary symptoms, to name a few, and it's very well recognised. Most of you, as patients, may have seen these or completed these at some point if you've seen urologists and or GPs. The GAD-7, this is a General Anxiety Disorder Assessment form, and it's a 7-item instrument, and that means there's 7 questions, and it's used to measure or assess the severity of generalised anxiety around the patient and around their coping mechanisms and what's happened in the past week or 2 weeks. So, some of the questions are, for example, have you had feelings of nervousness, anxious or being on edge, and you rate it as being not at all, over several days, more than half the days, nearly every day. Not able to stop worrying about symptoms, worrying too much about different things. So it brings in different aspects to the patient. And it gives, again, the therapist just a dialogue, even if it's simply a case of that there's one aspect of that particular form that you feel is important to open up dialogue around. And that can form part of a biopsychosocial approach to the treatment of male pelvic pain. Most therapists out there at the moment have got a really, really good grasp on the physical side of things, the biology of things. But the psychology and the sociology side of the condition aren't very well recognised or necessarily approached and treated. This just gives you a bit of an inroad. This gives you a chance to open dialogue and have conversation. And sometimes that's all that's needed. Sometimes that then may be a reason for you to refer on to another specialist, and that's a good thing. I think we'd be aware of our limitations as therapists as well. I think we should be mindful that there are a whole host of other resources out there that our patients could benefit from. The PCS, so this is the Pain Catastrophization Scale, and this asks the patients to reflect on past painful experiences and where they are now, and to indicate the degree to which they're experiencing each of the 13 thoughts or feeling when experiencing pain. So it's a bit of a cross comparison to past and present, and there are 5 points of the scale. So what I mean by that is at one end of the scale it's not at all, and at the other end of the scale the answer is all the time. So some of the questions might be, I keep thinking about how badly I want the pain to stop. Is this not at all, some of the time, most of the time, very infrequently, or all of the time? There's nothing I can do to reduce the intensity of the pain. I become afraid that the pain will get worse. I keep thinking of other painful events. I anxiously want the pain to go away. How much of the patient's thoughts are catastrophic? We know from the systematic analysis, from the paper I showed you beforehand, that catastrophic thoughts are really, really key in pain escalation and reduced quality of life and pain intensity and sense of disability. So this PCS form is a really great way of getting deeper understanding into our patients. The pain self-efficacy. And this takes into context pain in the account of the individual's self-efficacy beliefs. And what I mean by that is, how much can the individual lead a normal life, do things that they enjoy and take pleasure from? And some of the questions might be, I can live a normal life despite the pain. And again, there's a graded answer to this as to how much you believe this statement or how little you believe this statement. I can still do many of the things I enjoy doing, such as hobbies, leisure activities. I can socialise with my friends and family members. And I can gradually become more active despite the pain. And what the patient does is they tick a box, and again, it just opens up a dialogue. So how much is the patient able to engage in normal activity for them? How much is their symptoms and their pain disabling them from enjoying their life, from doing things that they take pleasure from? How much are their beliefs around their pain impacting their ability to go and do what they were been doing beforehand? And that's really important. The last one, the IPQRPP. It's a bit of a mouthful. Now, this is something I've come up with. This hasn't been validated. It's something I have used. I have adapted it from the Illness Perception Questionnaire. And the Illness Perception Questionnaire was a case of looking at a range of different aspects around the individual and their set of symptoms, their illness, if you like. And this included things like identity, cause, timeline, and consequences. So some of the questions that I've made up on this form, I've adapted it, like I said, from the original form. There are a number of different adaptations out there depending on the symptoms or illness or presentation or condition that the IPQ has been revised for. So in the form I have, it looks at things like other aspects of the patient's health. So things like weight loss, fatigue, stiff and aching joints and anxiety. And have you experienced these since your pelvic pain began? Do you feel that they're related to your pelvic pain? Then we move on to personal interests and other things about how the patient views their particular pain presentation. And the patient's asked to grade this as to whether they agree, strongly agree or strongly disagree, and every variation in between. So things like, my pelvic pain has major consequences on my life. My illness does not have much effect on my life. My pelvic pain causes difficulties for those who are close to me. My actions will not have an outcome on my pelvic pain. When I think about my pelvic pain, I get upset. My pelvic pain makes me angry. The final section is looking at causes, and I list a number of causes and ask the patient to assess from strongly disagree to strongly agree, and I actually give them a space to actually include their own beliefs around what they think is causing or has contributed to their pelvic pain. So some of the examples might be diet and eating habits, chance or bad luck, poor medical care, an operation, my own behaviour. They're just some examples of some of the potential causes. Now, like I said, there are many more forms out there, and I would encourage you to go and look up some others. The patient health questionnaire and the varying aspects, the varying levels of that is also quite a good way of getting an introduction to understanding as to what's happening with patients. So this isn't the way to approach. These are just some examples that you could use in your practice. And for patients, you may want to fill in some of these forms yourself, like I said, just to give you a bit more of an understanding as to other potential implications in your case. So I'm going to look now at some patient resources. These aren't exclusively for patients, and I would encourage therapists to consider some of these as well, or certainly to be aware that they're out there. These two options here, Greg Lehman's Recovery Strategies is a free download, available from Greg Lehman's website. Greg Lehman is, in my opinion, one of the leading authorities in pain and reconciling pain in the world at the moment. And his workbook it covers 4 main sections. It looks at pain principles, some of the key messages around pain, including some reconceptualization, changing beliefs and facilitating healthy behaviours. It looks at pain contributors and opens a dialogue for understanding some of the mechanisms and multiple factors of pain. And it looks at recovery strategies. So this is a self-audit for the patient to complete. So the final section is for the patient to complete and covers many of the aspects in the previous 3 sections. Now, this is great for patients to gain a deeper understanding, but it can also provide a recovery protocol or inroads into recovery protocol if and when used with a therapist. So it's worthwhile looking up. It's free. It's an easy, good read. There's lots of infographics. It's an enjoyable read, in my opinion, whether you're someone who is in pain or whether you're someone who's treating pain. Lorimer Moseley and David Butler's Protectometer. Bit of a weird name, but actually the book is fantastic. It's a great, great resource. I tend to use of these two. an element of the protectometer, the DIMS and SIMS, which I'm going to come and show you very shortly, over Greg Lehman's book, simply because, no offence Greg, but Butler and Mosley's protectometer and DIMS and SIMS model was available to the public before yours was. I still use Greg's approach with a number of my patients. It depends on the patient. Again, I don't use the same approach for every single patient. It's tailored to them. So what is the protectometer? Well, it is it's an interactive book again, a hard copy book. You can't download it as far as I know, although it might be available online. It incorporates over 20 years of pain science. There are loads of visualizations and areas and sections to fill in. It helps to map recovery, implement coping strategies, including graded exposure, and understandings of what pain and pain education are. And what's underpinning both this book and underpinning Greg's download is this notion of bio and neuroplasticity. And this is really, really essential, is that bio and neuroplasticity, and this may require another Facebook Live presentation, means that it's our ability to adapt and change. It means that we have the ability to recover, that we're not stuck this way, we have the potential to change. And this is a principle that allows us to be here as human beings. It allows us to develop and evolve as a race. It allows us to learn new languages, to recover from illness, to recover from broken bones, to do things that we haven't been able to do in our previous past. And this is a really, really key essence of recovery. So I'm going to show you something around DIMS and SIMS very quickly. Once my patients have completed their intake forms, sent them back, I've done the initial Skype. Between the Skype consultation and the face-to-face consultation, I get them to work on their DIMS and SIMS. What are DIMS and SIMS, Carl? DIMS are danger signals in me, SIMS are safety signals in me. And DIMS vary from person to person, as do the SIMS, but if we can identify what DIMS and SIMS are, then we can start to explore some of those DIMS and SIMS, some of those barriers to recovery and some of those inroads to recovery. And I get my patients to make their own list of DIMS and SIMS. They email them through to me before the face-to-face appointments, and we go through many of those in the face-to-face appointment itself as well. So let's look at some DIMS and SIMS, and we can see whether, in your opinion, as a patient and or as a therapist, you feel that these key words that I'm going to outline are DIMS, danger signs, or SIMS, safety signs. Are they things that improve and encourage recovery, or are they things that hamper and inhibit recovery? A holiday. Is a holiday, in your opinion, a danger signal or a safety signal? How far away is the holiday? How much flying will be involved? Who are you going with? Is it hot or cold? How do you feel about leaving the house? How do you feel about going somewhere that you haven't been before? Does it make a difference if it's a place that you have been before? A diagnosis. Is a diagnosis a scary thing or a really positive thing? If having a diagnosis means that you spend all your time on Dr. Google, is that positive? Or is having a diagnosis now that you understand a clear treatment path, something that's not really there in chronic pelvic pain? Stay in the hospital or a visit to the hospital. Is this something you feel is good and beneficial for you? Is this something that provides you with comfort and safety? Or is it actually a really, really scary environment for you, a place that you don't want to go? Sex. Is sex something that you take pleasure from, look forward to? Is it something that you enjoy? Or, conversely, is it now something you avoid? Is it something you fear? Is it something you wish you didn't have to engage in or even consider? Can you see where I'm going with this? Can you see how that DIMS and SIMS can change and vary from situation to situation, from patient to patient, and from patient to day, to circumstance, and situation to situation? These are just a few of the DIMS and SIMS that I might go through with my patients. And like I said, I get them to make a list of them themselves, and we explore them. It gives me an inroad into conversation with them. Okay. Let's continue with the resources. Let's continue to look at some other things that you may want to consider. So these are books. I'm a big fan of a book. You can probably see the bookcase behind me. These are two books. There are loads of books out there on pelvic pain, but these are two books that I feel fit my approach and they're also books that I can often lend to patients for them to read through. These are practical books. They follow the bioplasticity, neuroplasticity approach. They look at the chronic pain cycle. They go beyond the biology. They look at the psychology and the sociology. And they're two similar books. So I should point out that both Greg's recovery strategies and the protectometer are for pain generally. They're not specifically for pelvic pain. These two resources here, Why Pelvic Pain Hurts by Sandy Hilton and Co. and Pelvic Pain, The Ultimate Cock Block by Susie Gronsky, are much more relative to pelvic pain. It says so in their title. It does exactly what it says on the tin. And Sandy's book is a small, easy to follow, easy to read book. However, the message is really key. There's lots and lots of references in there, and I think it's good to have on your bookshelf. It's good to refer to. The 5 sections include understanding the body's alarm system, exploring the extra sensitive alarm system. So once pain is onset, why the body becomes extra sensitive. And understanding to pelvic pain. And this is the dilemma and the head, I was going to swear there, how much it messes with your head. The pelvic pain measuring cup, and this is a model I use, so how much you can fill your cup up before you get pain, how much it's important to keep that pain and the contents of your cup under control. The different types of pelvic pain, and the balance between tissue problems and a sensitive nervous system. Sandy also looks into a concept around the lion and the danger and perceived threat of pelvic pain and what it can actually mean to a patient. And at the back of it, there's some strategies, some management tools, some practical solutions for applications to treating and managing and dealing with pelvic pain. Great resource, something I lend to my patients, something that's well worth having a look at. Pelvic Pain, The Ultimate Cock Block by Susie Gronsky. This is if I say the language and terminology used here is fun, I mean in a really positive way. I think it's a really well written book because there are lots of medical references, lots of medical research to underpin the approach here, but it explores pelvic pain in a fun, open and honest way, but it doesn't take away the seriousness of the condition. There are a number of sections that include the theory and principles involved in pelvic pain. It explores some of the causes and effects of pelvic pain, and it gives an insight into the understanding as to what the hell is going on down there, what it is and what it's not. Some of the vicious cycles associated with pain and fears and worries and emotions that lead to that downward spiral. As with Sandy's book, it looks at the nervous system and the brain and its impact on pelvic pain as well. But like I said, it's important that you find a resource that resonates with you, whether you're a patient, whether you're a therapist. There is another page on my website that outlines resources for therapists and for patients. There are books and reference places to go through. Okay, I'm aware of the time, and we're going to start drawing this to a bit of a close now. So I guess my key message here is that there is an individual here in pain, and unless we're considering the individual, we're kind of missing the point. Each patient should be seen as an individual, and each session needs to be tailored to the individual to allow the greatest chances of recovery. If this means exploring the multiple facts around pelvic pain, then surely this is paramount. Surely this should be the way we go forward. If we want the best for our patients, then we have to provide the best for our patients. And this means understanding them on a biological, on a psychological and a sociological level. This means looking beyond just the tissues. It means looking at the multiple aspects that bring a patient to us. A patient is more than just the sum of their own symptoms. That's really, really key. They're more than their prostate and their bladder and their penis. There's much, much more. We can have a curriculum to follow. We can have key messages, but they need to be delivered in a variety of different ways. And whether this is adapting the language and terminology we use based on the individual who's in front of us, maybe it's adapting it and changing it and reinforcing it at each follow-up session. Maybe it's using an iPad to show graphics, infographics, resources, videos. Maybe it's metaphor, maybe it's story. But we have to focus on the individual. I can't deliver the same message I can to someone who works in in the medical world that I can, based here in England, that I can to my patients that come from the Middle East. It's just not possible. I can't use the same language. I can't use the same terminology. My Arabic's not that great. So therefore we need to find a common ground, a way in which we can explore those messages. We need to meet our patients halfway. We need to move forward, listen, engage, sit back, listen again. Allow patients to explore some of their worries and fears and concerns. Give them time. This isn't a quick fix. And I think, again, we need to be open and honest with patients. It's a process. If you like, and it's a bit of a cliche, it is a journey to move through this, to have an understanding as to what's going on. There may be a whole host of causes that are contributing to the patient and their patient presentations. And we may need to go and undo some of what they've been told previously from archaic methods, from out-of-date medical approaches, from some of the information, from some of the words, from some of the flippancy and the dismissal they may have received up until this point. There is an individual in pain. We need to remember that. There is an I in pain. There is a person there. All right. I'm going to show you, this is the final slide, penultimate slide. This isn't me. You might think it is me. Well, here we go. So I found this on my mate's Facebook page. I think this is an amazing tattoo. I love this. And I want you to have a final thought. This links in a little bit to next week's presentation about who drives who, about who's in control or what is in control of our bodies. And I'm going to get you to consider three things, three elements here. So this is the physical body, the vehicle that we move around in. Then the conscious mind, and then the subconscious mind. And I want you to consider who controls who out of this. I want you to consider, is it the body that controls us? Is it the conscious mind? Is it the subconscious mind? And why is this, why is this relevant? I want you to consider how much the conscious mind controls the body versus the subconscious mind. So let me reiterate that. I want you to consider how much our conscious mind, our conscious awareness, controls everything that happens in our body, including pelvic pain, versus our subconscious mind, and how much on comparison. So, for example, is it 50-50? Do you feel that the conscious mind and the subconscious mind are split right down the middle, that there's 50% control over the body consciously and there's 50% control over the body subconsciously? Is it 60-40? Is it balanced slightly? Is it weighted slightly heavier to one side more than the other? And I want you to consider this because it's really key in understanding management of symptoms and management of the patient and an understanding around chronic or complex pain. And when it comes to education and giving a patient understanding around what's going on, this is a really, really strong consideration. So that's pretty much it for today. Here I am. So thank you for joining me. I hope you found today beneficial. I hope you've enjoyed it. I hope, if anything, it's just aroused some curiosity. I hope it's made you think a little bit outside of the traditional box that we've associated with chronic pelvic pain syndrome and prostatitis. I hope it's given you, as a patient and as a therapist, some inroads, some different understanding as to what's going on. Like I said, I'm not the oracle. I don't know the answers, but I just want to encourage a greater understanding and a greater curiosity about the condition. If there's other ways in which we can help our patients and get greater results, get more conclusive and long-term results, then for me this is a great way in. This is an ideal opportunity to understand the individual in pain. I've been Carl Monaghan. This has been the BioPsychoSocial Approaches to Treating Chronic Pelvic Pain and Chronic Prostatitis, Part 2. I will be back here Thursday the 21st of December at 11 o'clock to discuss hard flaccid. And I will answer the question that I just posed around conscious and subconscious and the body and who and what controls what. I want you to consider that, and I want you to get involved in the process. So I want you to, based on a percentage, 50-50, 65-35, testing my maths, 60-40, whatever you feel the percentage is and which way it's weighted, subconscious or conscious, pop it underneath the video. Place a comment underneath here. Let's get this involved a little bit. Let's get some conversation and dialogue going through here. Like I said, thank you very much for joining me. I hope you found it beneficial. There will be a blog following this with all the references and supporting material on there. If you have any questions and queries, feel free to make a comment underneath the video. Otherwise, I look forward to seeing you next week. And like I said, there'll be some more presentations coming in the new year. Thank you.